useful model that I would assume is quite applicable to this area of the world, which has hepatitis B acquired vertically, which has a high risk of liver cancer. This is the model. It's a score system, so sex, age, ALT, E antigen positivity, and the levels of HBV DNA. And this is an example. If you have a 60-year-old HBe antigen man with an ALT of 47, HBV DNA of 50,000, their score is 13, and if you put that on the percentage, you can get the predicted risk of hepatocellular carcinoma. This is useful for two things. First, people want to know. Second, it gives you a threshold when you start screening or surveillance for hepatocellular carcinoma. The presence of alcohol alone can cause liver cancer through cirrhosis, but alcohol really operates worse or considerably stronger in the presence of either hepatitis C or hepatitis B. So this slide shows three curves. The highest one is alcohol with hepatitis C infection. Next is with hepatitis B infection, and the lowest is just alcohol. What is alcohol? Meaning greater than 50 grams of alcohol per day for a long time. That's not just a social drink like what we're going to have in today's dinner or tonight's dinner. It's way more than that. Okay. In the United States, in liver meetings, in EASL, and ASLD, if you go to them today, yes, people are still talking about hepatitis C and hepatitis B, but they are really talking about non-alcoholic fatty liver disease. We think there is an epidemic of this disease. In the United States, among adults, estimates round anywhere between 20 to 40%, depending on how you measure it, of people might have non-alcoholic fatty liver disease. We don't know exactly the natural history of this disease, but we think that progressing from mild or bland steatosis into non-alcoholic steatohepatitis with inflammation, necrosis, and laying down of fibrosis happens in 10 to 20% of NAFLD. And then we think that 10 to 20% of patients with NASH might progress to cirrhosis. And then once you get to cirrhosis, no matter how you get there, your risk of hepatocellular carcinoma starts zooming up. That's what we think happens. But how does that work? Because it ties into other reasons where liver cancer risk increase, is we think that the underlying lesion behind non-alcoholic fatty liver disease is insulin resistance. That is characterized by high blood pressure, high triglycerides, low HDL, visceral obesity, and influenced by genes and diets. So that we think that everyone with non-alcoholic fatty liver disease has some level of insulin resistance, whether overt, such as diabetes, or occult, something you measure by a HOMA IR. So what is the evidence behind the link between NAFLD and HCC? Despite the hype and the enthusiasm and the potential for a real link between the two, the data are still preliminary and infantile. Actually, of the two population-based studies that examined this question, one of them found no HCC in NAFLD, and another one found a very low incidence of HCC in non-alcoholic fatty liver disease, and you would expect that. It will take a long time, a lot of people, in order to get robust estimates. But if you look at class 1 level evidence, which is population-based prospective studies, there is really no link between the two. What is present that in clinic-based studies of NASH or NASH-related cirrhosis, there is a clear increase in the risk of hepatocellular carcinoma. So prognostication for just a regular person with NAFLD about the risk of HCC is quite unclear at the moment. But once they hit the threshold of NASH, and particularly cirrhosis, one can tell them that the risk is increased by several folds. So talking about diabetes. Diabetes has been examined since time immemorial as a possible risk factor for hepatocellular carcinoma, and something that happens in almost all cross-sectional studies, but in the case of diabetes, it's really true in liver cancer, is the chicken or the egg. And the reason is If you see someone with liver cancer and diabetes at the same time on arrival, there's absolutely no way of knowing whether diabetes was first present, caused NAFLD went to NASH, then caused liver cancer, or there was cirrhosis, which is known to produce glucose intolerance and diabetes, and then hepatocellular carcinoma happened. There's absolutely no way of telling by the usual design of case control and cross-sectional studies. So what we've done is a cohort study, which means we took patients with diabetes, patients without diabetes, everyone with no liver disease, followed them over time for almost 14 years, very large number of patients with diabetes, 173,000, 4 times the number of controls. And as you can see from this graph, the incidence of hepatocellular carcinoma is almost double among patients with diabetes compared to those without diabetes in this prospective cohort study done through the administrative database of the VA. If you look at the y-axis, you notice the absolute risk. The absolute risk is quite small. I mean, it's a percent of 100% of diabetics, so it's not a huge absolute risk. But don't relax too much. Diabetes, obesity, and insulin resistance are so common that all you need is a little bit of increase in the absolute risk to translate into a lot more cases than hepatitis B or hepatitis C. So, not just diabetes, but the treatments of diabetes. There's a recent systematic review and meta-analysis that shows metformin out of the treatment of the diabetes treatment might be associated with 50% reduction in the risk of hepatocellular carcinoma, whereas insulin and sulfonylureas might be associated with an increase of the risk of hepatocellular carcinoma. So we're done with risk factors. I'm going to change gears and talk about prevention. Talking about hepatitis B vaccination. This has been one of the major victories of science. It's a vaccine that was implemented that prevents hepatitis B, and the Taiwan experience, which was one of the earliest to implement a program of vaccination with selective H given to the mothers, has produced a drop in HCC incidence in childhood, which recently is documented in early adults. It's amazing, frightful, as well as sad that you can wipe out half of the liver cancer cases in this world by this safe, effective, cheap vaccine that most people cannot get. That's why the rest of my talk will be about expensive, less useful things that everyone else can get. So, next, on a lighter topic, coffee. So coffee drinking has been associated with normal or decreased liver enzymes, particularly GGT and alkaline phosphatase, in numerous studies. Coffee drinking has always been inversely associated with the risk of cirrhosis of multiple reasons, both hepatitis B and hepatitis C. Coffee has been inversely associated with the risk of hepatocellular carcinoma in both case control studies and cohort studies that have been recently compiled in systematic reviews and meta-analysis. The bottom line from both of them that for each additional cup of coffee, there's a reduction of the risk of hepatocellular carcinoma by almost 23%. Now, there are a few technical points here. It's coffee. It's not decaf. No, I didn't mean it as a joke. This is a real observation. And it's coffee. It's not tea. And you have to watch it here, being an epidemiologist, how you interpret those odds ratios. So if you take this literally and multiply by 10, you will never die of anything at this point. But of course, there's a ceiling effect or a bottom effect below which you cannot obtain any further benefit. Why does that happen? There's some neat experimental evidence that coffee and caffeine have some antioxidant properties and antineoplastic properties. The explanation I like the most, that coffee drinking has been inversely associated or a protective factor against the development of diabetes and insulin resistance. So if you believe the plot about NAFLD, NASH, and insulin resistance, then coffee fits right in. Okay, Statins. A few years ago, we started the flood of statins in a study for hepatocellular carcinoma done in the VA. So we've shown in a large diabetic cohort, in a nested case control study, that those who were treated by statin, but not by any other lipid-lowering class of medications, were associated with almost 40 to 50% reduction in the risk of hepatocellular carcinoma. Clearly, this is observational. Case control has multiple biases. It was followed by several other studies that were recently summarized in a systematic review, and they basically all the observational studies show a reduction in the risk of HCC. All the clinical trials don't show any reduction. They were all done for cardiovascular endpoints. All the studies, which is quite unique and interesting, show that it's a statin-specific effect, not with the other stuff, not with cholestyramine, gemfibrozole, or niacin. It's much stronger in studies that came from Asian countries. It's much stronger and consistent in hepatitis B infected patients. Many things remain unclear. No one really knows the real dose, the real duration, or whether lipophilic versus lipophobic statins have different effects. Finishing now the pharmacoepidemiology, let's talk about surveillance. In the United States at least, and I suspect everywhere else, there's been a row about screening for liver cancer. There's a publicized editorial in the Annals of Internal Medicine called Screening for Liver Cancer, Rush to Judgment, Misplaced Confidence in the Chinese Trial, that led many writers to accept the effectiveness of HCC screening as proven, making it more difficult to conduct high-quality randomized trials. So there's that. So what are they talking about? I just told you that cirrhosis is the risk factor for hepatocellular carcinoma. It's a fact. There have been no randomized trials done to test surveillance in patients with cirrhosis. I told you that in many countries, hepatitis C is the main risk factor. It is a fact that there have been no randomized trials to test surveillance in hepatitis C patients. I told you that hepatitis B is the main risk factor in many other countries, and it is a fact that there have been 2 randomized trials, both done in China. One showed benefit, the other did not show benefit. People jumped, maybe rightfully so, on the positive study and made it as the crux of the guideline, and based on that, the ASLD guidelines came and said, recommend screening. So, since there are no trials, all the guidelines that you can read about are based on this idea of risk, which tells you epidemiology is really, really important. So they figured out any condition that the risk, the annual risk of hepatocellular carcinoma exceeds 1.5%, you're in. Screening and surveillance for hepatocellular carcinoma is recommended, which you don't have to remember many things. It's cirrhosis and few subgroups of hepatitis B, basically older men, older women, family history, and Africans with hepatitis B. So generally, the surveillance recommendation are those with cirrhosis and hepatitis B infected. Ultrasound and alpha-fetoprotein are recommended screening tests. The ASLD and EASL guidelines now has recommended dropping alpha-fetoprotein, and I think it is a mistake. Those of you who are involved in this controversy know. I still believe of alpha-fetoprotein, and why? Because that Chinese trial that led to the guidelines adopting screening used alpha-fetoprotein combined with ultrasound every 6 months. So it's the only class 1 evidence that we have, and they used alpha-fetoprotein plus ultrasound. In the US, the only population-based study done in hepatitis B in Alaska used only alpha-fetoprotein and showed efficacy. And as I'll show briefly, most people use nothing. No ultrasound, no alpha-fetoprotein, no CAT scan. So by dropping an easy test out of the armamentarium, we're not helping the cause of screening. The third line of prevention, so we talked about coffee, we talked statin, we talked vaccination, we talked screening, and now treatment. It is clear now that the reverse of a high HPV DNA, that is a low HPV DNA induced by treatment, results in a reduction of the risk of hepatocellular carcinoma. That has been shown in a randomized controlled trial in Taiwan that basically was